Bismillah ar-Rahman ar-Rahim. Welcome to ERA. I am Dr. Muhammad Talat, Assistant Professor of Radiology at University. Today we will continue our course, and in the last video we discussed or we illustrated a very challenging case. Let us review together the case. This patient was presenting with acute deterioration or acute loss of conscious level, and we have here on the left side an area of encephalomalacia along the territory of the left middle cerebral artery. Also, when we started to review our case, we found that there is right MCA sign, acute thrombus along the territory of the right middle cerebral artery. And our message here is that every time you should check your checklists, and also don't be satisfied by the obvious lesion or obvious abnormality. Please check all things, all points in the study according to your own checklist. So according to our recommendations at the time that we need to do CT angiography for this case to check and to confirm acute thrombus or acute. So our recommendation in this case at the time is to do CT angiography for the neck and the brain to confirm this acute thrombus and to check the cerebral circulation. We did CT angiography for the same patient, and we have two teaching points before reviewing the findings. First, the CT angiography for the cerebral arteries. In our routine practice, we should include the neck. So we should start from the aortic arch, covering the neck and covering the whole brain. The second teaching point here in the technique, regarding the technique itself, I prefer to take two sequences from, or two series of images from down to up to finish the whole brain, and to take second series from above to down consequently without any gaps in timing. Because sometimes after injection of the contrast, may the patient move, maybe the patient is irritable. So the second phase of contrast injection can help you to cover any missing data or any missing segments during the scanning of the patient. Let us review our findings, and let's go by the posterior circulation. We have here both vertebral arteries. Both vertebral arteries are patent. If we need to trace the vertebral arteries from down to above, the vertebral arteries are patent. And here, the intracranial segments of the vertebral arteries are patent. They are united together to form the basilar artery. This is the basilar artery. It's patent, showing average caliber without any occluded segments or without any significant stenotic lesions. And here, the basilar artery is divided into cerebral arteries, as you see here. Those are the posterior cerebral arteries on both sides. So we review together posterior circulation. We don't have any abnormality, any significant abnormalities. Let's go to the anterior circulation. This is the left common carotid, and this is the right common carotid. Let's start by the left side. This is the carotid bulb before division. And this is the external carotid artery, and this is the internal carotid artery. The internal carotid artery, as you see, there is an abrupt occlusion of the internal carotid artery shortly after its origin. This is the patent segment, and it shows abrupt occlusion, while the external carotid artery is still patent. Let's trace this occluded segment. We don't have any patent segment of the internal carotid artery, and as you know, we have four main segments of the internal carotid artery. First is the cervical portion. This is the cervical portion of the internal carotid artery. And we have also the petrous portion of the internal carotid artery. And this one is totally occluded. It's not enhancing. So we have two segments now, cervical and petrous portion. And we have also the cavernous portion of the internal carotid artery. This is a normal location and it's still occluded. And we have also supraclinoid portion of the internal carotid artery, and really it's still occluded. If we go more distal, we will find the most distal end of the left internal carotid artery appears patent. So we have collateral filling of the most distal end of the left internal carotid artery. The left internal carotid artery gives rise to two branches, the left middle cerebral artery, and the left middle cerebral artery appears patent and average in caliber, and gives rise to another branch. This is the E1 segment of the anterior cerebral artery. So both branches are patent, and the E1 segment of the anterior cerebral artery are supplying the right anterior cerebral artery, A2 segment, and the left anterior cerebral artery. So the right anterior cerebral artery is supplied through the anterior communicating artery from the left side. So both anterior cerebral arteries are patent, average in caliber. The left middle cerebral artery appears patent, even its distal branches appear patent. And at the same time, we have an evidence of old cerebral infarction along the left middle cerebral artery. So for sure, this left middle cerebral artery shows evidence of recanalization. This is our review for the left side. Let's move to the right side. We will start also from down to up. This is the right common carotid artery. It appears patent with no occluded segments here. It is divided into external carotid artery and internal carotid artery. The internal carotid artery courses medially, this one, having a retropharyngeal extension, this is a pharynx, and it goes, or it moves more medially, it is tortuous and go up. This is the internal carotid artery, as you see here. The internal carotid artery, the cervical portion is patent, as you see here. Still, we are tracing the internal carotid artery. Here you can change the window to check the internal carotid artery because it goes inside the petrous portion. And as you see here, it is patent. Look for the enhancing lumen of the internal carotid artery inside the petrous portion. Here we have also the cavernous portion. It is difficult to pick up the internal carotid artery and the cavernous portion because it is markedly attenuated, but it is still patent. Look for this one. It's markedly attenuated, but still patent. You can hardly trace the internal carotid artery at this segment, and it shows abrupt occlusion at the supraclinoid portion. So we have here abrupt occlusion of the right internal carotid artery at its supraclinoid segment. And also, this is the left side, left MCA. We don't have any evidence of enhancing right MCA on the right side. Look for this area. This is a presumed site of the right MCA, but it is totally occluded. And there is evidence of paucity of branches along the right middle cerebral artery as compared to the left side. So we have evidence of abrupt occlusion of the supraclinoid portion of the right internal carotid artery and occluded right middle cerebral artery with paucity of distal branches, distal cortical branches. Let us review the 3D image. As you can see here, this is the precuspal artery, common carotid artery, external carotid, internal carotid. We don't have any significant abnormalities. Along the left side, we have left common carotid, internal carotid artery, external carotid artery, and we have here occluded segment, occluded long segment of the left internal carotid artery. You should check also the 3D image. You should trace the whole arteries. Once we start to trace the whole arteries, we will find stenotic lesion along the proximal half of the left common carotid artery. We are not sure is it real or not. We should check the thin slice image again. So in our routine practice, you should check the thin slice or volume image and the 3D image. Once we have any abnormality in each one of these modalities, you should check the another modality to check is it real or not. For example, we had here something abnormal along the left common carotid artery, and we didn't see it before in the thin slice image. So you should check again the thin slice image. Let us check again, but before check the stenotic lesion, if it is present, you have to measure the length of the stenotic lesion in the coronal plane, and in the thin slice image, you should check is it real or not, and if it is real, you should check the luminary reduction. How much is the percentage of luminary reduction? Is it significant or not? Check the thin slice image. We have here the aortic arch, and the aortic arch gives rise to 3 normal branches arising in normal order: left subclavian, left common carotid, and brachiocefalic artery. And this is the brachiocefalic vein. Here, the left common carotid artery. Let us focus in this artery. It looks like stenotic lesion in the common carotid artery, but really it is not typical location. The typical locations for any stenotic lesions are the carotid bulbs, so we need to check again and again. If it is real stenotic lesion, I think it doesn't cause significant luminary reduction. I think it is less than or equal 50%. The significant stenotic lesion should be above or equal 70% in luminary reduction. But let us think again, what is the explanation for this stenotic lesion? Maybe there is something like beam hardening artifacts. If you can concentrate in the image again, you will find something like beam hardening artifacts, maybe secondary to the condensed contrast medium, injected contrast medium along the left subclavian vein, maybe making this one or misdiagnose this one as a stenotic lesion. How can we solve this challenge? I think the most important part to solve this challenge is to see the second phase. As we discussed before, that in my routine practice, I take 2 phases, from down to up and from up to down. Let us see the second phase of contrast injection. Let's check our second phase. Let's focus on the left common carotid artery, this artery. We don't have any condensed contrast along the left subclavian vein, but we are still having some beam hardening artifact along the thoracic inlet, as you see here, these lines, these fine lines. But really, it doesn't affect the image too much. And we don't have any stenotic lesions, any cross or significant stenotic lesions along the left common carotid artery. So checking the second run is helpful in this case. If we need to check again the volume rendering 3D image, as you see, the first run, you have a significant stenotic lesion, while in the second run, nothing. No evidence of any significant stenotic lesions. So for sure, it is pseudo stenotic lesion. This stenotic lesion induced by beam hardening artifact by the contrast medium in the left brachiocefalic vein, as you can see here. This is the first run, and this is the second run. No evidence of any stenotic lesions. Last thing that I want to add, we have something called bovine configuration of the aortic arch branches. Here, the left common carotid artery and the brachiocefalic artery arises from one common stem, and this is considered as a normal variant. Normally, the left common carotid artery is arising separately from the aortic arch, but this one arising with a common stem with the brachiocefalic artery. I hope you enjoyed our practice or our reading session in this CT angiography study, and thank you so much.